Hi, I'm Tom Myers, and I'm pleased to welcome you to part 2 of our program on the deep front line, the last in the series of programs of techniques for the anatomy train's myofascial meridians. In this program, we're going to explore techniques and approaches for the upper part of the deep front line. We're going to assume that you have watched and taken in the other programs in this series before you start applying the core techniques that we're showing here. In this program, we're going to show deep front line techniques from the waist up to the neck. Although the various other programs in this series, the front, the back, the lateral, the spiral, the arms, and the functional lines, can be taken separately in any order and are pretty much co-equal, there is a real sense in which the deep front line program is the last. What we mean by that is that we highly recommend that you undertake the work on the other programs, the more superficial work, with any given client before you undertake the deeper work you're about to see on this program. The deep front line is also called the core line, and it contains muscles and fascial structures usually referred to as core by the Pilates folks, PTs, and the followers of Ida Rolf. The recommendation here is that superficial structures need to be loosened and differentiated before you dive into the deeper structures of the core. In fact, too much core work before you loosen up those superficial structures can be damaging and leave the client worse off than before. So please, enjoy this program and these highly effective techniques, but please use them wisely, putting them to work after you've done several sessions opening up the superficial tissues and after you've established a good rapport with the client. We call this line the deep front line because it runs right up the front of the spine. It's way deeper than the superficial front line, which runs up the surface of the belly and chest. But since the deep front line runs up the front of the spine, it's still clearly an anterior or front line. In the leg, the deep front line runs a complex route from the arch up to the groin, but it essentially runs up the inner seam of the leg, and it counterbalances the lateral line that runs up the outer seam. In the spine, the deep front line runs right up the anterior longitudinal ligament from the pelvis to the head. This is also the attachment point for many of the organs of the chest and abdomen. Without making this into a long lecture, although I hope you'll come to a class sometime so I can explain it more fully, this front of the spine area, where the deep front line runs and the anterior longitudinal ligament is really the junction between the organs that hang off that ligament and hang off the spine and our neuromuscular self that surrounds it. So in a very real sense, when we're working in the deep front line, we're working on the boundary between our organic being and our neuromuscular doing. In practical terms, this means two related things. One is that when you're working on these tissues of the deep front line, you're working on the boundary between the autonomic system, the sympathetic part of it, the fight or flight system, and the parasympathetic, the repose and repair system. So what this means is that we're at the somato-emotional core of the client, and sometimes working with these techniques gives the client access to emotions that maybe you or maybe they didn't even know they had. This in turn means that we must work sensitively and with close attention when we're working with these tissues, and allow the client room to express themselves. Ida Rolf urged us to evoke the core. That means to call it out or call it forward, as she said. When you're working with core tissues, you're working with the human being, or you're working with the inner self. It's not just a question of pushing tissues around to correct things. Without getting too new agey about it, working with these core tissues really does require that we be present and that we call the client to be present as well. Which leads to my final caveat before we start working. A lot of pain can be stored in these tissues. The design of this work is to take pain out of the body, not to put it in. Be very careful of the level of sensation that you induce when you're doing these techniques. If your client's trying to get away, you're doing something wrong. There are many other techniques for the deep front line, including techniques around the throat and the pelvic floor, which we simply don't feel comfortable teaching on video. If you come to a kinesis class, we'd be happy to teach you those techniques in person, hand to hand. In summary, these techniques work best when applied slowly, with attention and presence, and with the client's cooperation in movement and in opening an area to new feeling. The rewards of these techniques are great in changed posture, in stress reduction, and in pain reduction, but those rewards will come only with sensitive application.
The
deep front line starts deep in the plantar surface of the foot, runs up behind the calf in the deep posterior compartment, swirls around to the front on the intramuscular septum, picks up the psoas, goes to the front of the spine, and follows the anterior longitudinal ligament all the way up to the skull. In that interface between the organic body and the musculoskeletal body, this is the deep front line. Ida Rolf used to joke that the psoas was a muscle of breathing and the diaphragm was a muscle of walking. They're definitely part of the same complex. So work on the deep front line in the upper body requires techniques for both the diaphragm and the psoas. Relevant techniques for the psoas are here repeated from our first program on the deep front line, the one on the lower body. Now, there's a lot of controversy around contacting the psoas muscle, but for my money, it's a good place to be because I want full awareness for the whole body. So in contacting that, though, I do it a little bit differently from how you may have been taught it, if you have been taught it before. Go right over the ASIS, same as we did for the iliacus, and here I go, sliding down the slope of the iliacus. I must sooner or later run in with my fingertips into the psoas. Of course, I could also run into an intestine here. How do you know the difference? The difference is when she lifts her foot off the table, the psoas gets tighter and intestines don't. So I'm pretty sure I'm on the muscle there because as soon as she lifts her knee, boom, there I am on the muscle. Now, in terms of opening this muscle, I want to be very careful and very slow and very deliberate here because I am working through 2 layers of peritoneum. You can't not be. You may not be pressing on an intestine or stretching anything, but you cannot avoid going through 2 layers of peritoneum. So I swim, I'm sensitive, I let her do most of the work. I come up against that outside of the psoas or perhaps against the top of the psoas. But now, what I'm going to ask you to do, Leah, is take your knee out over your second toe. Now, I'm being very precise here saying the second toe, but that's where we really would like it to go. And at least over the toes, not with the knee going to the side, either the outside or the inside. And then I just use my fingers as guides here to help open tight places. And you may notice that where I'm looking is not where I'm working, but in her eyes. The psoas is such a deep muscle, so close to the core, such a toxic waste dump sometimes, and so important that I want to know where Leah is at. And the eyes are the window to the soul, and the psoas may be the most important structural muscle, but yeah, right there. Yeah, now I found a place where I really would like to open that. And that's probably enough. That was a fairly long move. And if this was the first time that anybody had been in Leah's psoas, I probably wouldn't have been there so long. You really will excite stuff out here. This is a muscle that carries a lot of garbage in it, and if nobody's ever been touched there before, probably a smaller amount of work is going to be sufficient. If somebody has more experience, you can stay there longer and work with this motion. Now, whatever you do in the iliacus and the psoas, make sure that you finish up with a balancing move that includes both sides. This is not hard, it's not difficult, should not be painful, but it is important. So I put my ring finger on the 2 ASISs, right up against those bones, and I have 3 fingers located across the body here, and I'm going to drop back into the same area that I've been working. So the iliacus is against my ring finger, the psoas is against my index finger, and I'm dropping into this corner of just above the hip joint, essentially. Yeah, that's okay? And now I'm going to have you take both knees out over both toes and tuck your tail under. And then I can just fall back. Sean, if you'll notice, I'm just falling back in. And now lower it 1 vertebra, that vertebra, then the next one, then the next one, then the next one. Like it's a whole chain of dominoes coming down. And I just keep my hands in here. It is not a big, heavy move. I'm just guiding her psoas and checking the tonus of the 2. So, ring fingers against the ASIS, drop in, dropping back, not to where it's painful, but to where I'm in contact. Now, tuck your tail under and send your knees out over your toes. Ooh, slower, okay? So, tuck under slowly, send your knees out over your toes, and There's where your vertebrae are. There's where your psoas is. Now just drop the topmost vertebra back on the table, and then the next one down towards your sacrum, and then roll into your sacrum. This opens up those vertebrae between L4, L5, and S1 so that you can really get your back long and flat. Okay, Sean, give it a try. You okay for him to come in?
Yes.
Now? Yeah, it should be gentle, not stressful. Okay, so make sure your ring finger is right on there. Your fingers are horizontal, and you just drop back there. And you're reaching across with one hand, so use the pressure in your fingers to make sure that you're quite even on that. Does that feel similar? Okay, so now drop your pelvis back and take this up. All right, so don't turn your fingers in too much. You're still going down towards the table. Yep, that's it. Are you getting a similar feeling with him that you were getting with me? Yeah, good. So you use the cue. What do you want to do?
You want to just drop your top of your lumbars and what did you do again?
Yeah, the cueing is really important. How you talk to the client. Okay, no, you keep your hands there. That's all right. We'll do it. It really helps if you get the proper cueing for this. So come on up with tuck your pelvis under, send your knees out over your feet. Yeah, and now drop whichever lumbar is off the table, and then the next, and then the next. And you just follow it, kind of exploring in, keeping those two psoases balanced as she comes down all the way to where you're resting on the table.
Great.
Yeah, got it? Okay. I do want to show one other way of reaching the psoas. It's a one-sided way. When you can't do this thing on the back, you can adopt this alternative way. Okay, so let's see one alternate way here of working with the psoas in side lying. It has one disadvantage and two advantages. The disadvantage is that side lying, working with the psoas side lying, is not as good as way of working as lying on the back in terms of the position of the psoas and the balancing between the two. The two advantages are, one, that the organs fall away from you, so you're less likely to get involved with any intestinal attachments as you come back here. Now, the way to get back here is to slide your hand back along the iliacus the same way that we did until you contact the psoas. Are you unsure as to where the psoas is? Just put your hand on the model's knee, and she presses against my hand. In other words, she flexes the hip against resistance, and I can boom, boom, feel the psoas right in there. And now we get to the second advantage here, because now that I've got the psoas, and I can explore it, and I can hold the back of her hip with my hands. So you see how my hands are opposed. And now, Leah, just bring your knee back, and keep bringing your knee back. And that's the other advantage of this side lying position, is she can go way past just being straight to actually hyperextending the hip. Okay, come back around again. So watch, she starts from flexed, I'm holding on to the psoas, I'm stabilizing the hip, and she goes past that as if she were running, as if she were leaping off her leg. Okay, bring it on back. So there is an advantage there, but you obviously can only work one side at a time, so be sure that you finish up with that lying on the back, two-sided move to keep things balanced. Now the last part of the psoas complex here, besides the psoas and the iliacus, is the quadratus lumborum, or as my French student calls it, le carré des lombes. I like that better than quadratus lumborum. But QL for short, runs right down through here, and many people say, okay, I'm going to work on the quadratus lumborum, working here in the lower back. Well, as an anatomist, I'm here to tell you, you can't reach the quadratus lumborum from the back like that. You may be doing great work in the thoracolumbar fascia, you may be doing great work with the iliocostalis, but you're not going to get the opening or the balancing between the rib cage and the pelvis that you're going to get if you really get the QL. So there's technique on the QL, but first there's finding it. If you reach over the edge of the iliac crest so that you're on the inside of the iliac crest, somewhere forward of the midline. If you see I'm anterior to the midline here. Now I walk my fingers back along that midline and I find this piece. So Leah, you feel the difference between doing this and doing this? What's the difference? How do you...
It's so much deeper where you are right now.
Mm-hmm. Got you really by the quick if I'm here. Okay, so this, where I am right here, is the outer front edge of the quadratus lumborum. Outer front edge of the quadratus lumborum. So I'm going to reach around, hook my fingers over that, and bring it down and back. And perhaps you could hear Leah taking a breath or see her taking a breath. Her breathing is really helpful in opening this, and so is this idea of bringing the hip away from the shoulders. But just to demonstrate this is not how I work it, but I just want you to see it with the fingers. I'm coming down in on the midline and then hooking this muscle back towards the back. Now, I said muscle. I make that mistake sometimes. But the muscle and fascia together here, this is a very important part of this complex because the quadratus lumborum continues on into the iliacus. So when you free the iliacus, you've freed half of it, and when you free the quadratus lumborum, you've freed the other half. What I don't want her to do, I'm very happy for her to reach down this way with her hip. What I don't really want her to do is to reach up with her arm. Try reaching up with your arm. Now reach way up there. Wouldn't you think that, just stretch your hand way out. Now, wouldn't you think that that would stretch out this quadratus lumborum? But instead, it tightens up the latissimus that's running over here, and then you can't get into the QL. So bring that arm back down again. If you want to have her open this up, I'm sorry, this is a very touchy area. Just use breathing as you bring that edge down to the hip and back. You don't want to push up on the QL too much because you're going to encounter that 12th rib, and that's a slippery and delicate little devil, and you don't want to push too hard on it. Now, in the other program, we'd gotten as far as the psoas, and the psoas, after it crosses the hip, goes up here behind the organs to attach to the front of the spine and the anterior longitudinal ligament. The diaphragm is also coming down to end right in here. So that this area, where the psoas and the diaphragm meet, right behind it is the thoracolumbar junction between T11 and T12, T12L1, very important area of the spine, and right in front of it are the adrenal glands and the solar plexus. This is an incredibly important area, but you can't reach it directly on most people, too much stuff in the way. So let me show you a technique for reaching this area indirectly. So if the inner seam of the leg and the front of the hip is key to the lower part of the deep front line, then breathing is key to the upper part of the deep front line. We have Leah here to help us this morning. And this place where the psoas goes behind the organs and meets the diaphragm, which is also coming around behind the organs, is not a place that you can go to directly. If I were to attempt to go back there, I just don't recommend it. Unless your liability insurance is way paid up, let's not do that. However, we can reach it indirectly with a much, much simpler technique, which simply involves the client using the breath. So if I take my hand and put it on the client's belly between the navel and the costal arch, I'm not pressing down on the ribs, but merely on the muscles of the belly, and then I ask Leah to breathe in, especially to take a belly type of breath, and I don't allow the belly to come forward. Not with a great big heavy weight, about the weight of my arm is enough. And that directs her breath into other parts of her abdomen. Can you feel it somewhere else?
I can feel it in my sacrum and pelvic floor and up into my scalenes.
Okay, so by not allowing the abdomen to come forward, the breath is directed down into the pelvic floor, and she can feel it up into the scalenes that we'll be working with later. Now, there's no point in having this video go on and on forever because the technique is the same, but I recommend that you keep this going for a few minutes and keep directing your client's attention into different parts of the abdominal balloon. She might feel it in the quadratus lumborum, in different parts of the pelvic floor, And if I just keep directing her breath down into the belly, and I keep enough of a weight on there and say, now where do you feel it? And now,
Lumbars.
now you feel it in the lumbars. It'll change over minutes. Okay, so I'm going to ask you to feel it in the back of your diaphragm. See if you can feel that back of the diaphragm. Ah, yeah, that's good. You feel that right down.
Oh,
that's
yes.
that's where the psoas and the diaphragm meet. If you want to, you can add a second thing to this, which is put a hand just under the spine behind you. I just go ahead and relax down onto my hand and keep this hand here, and now take a breath. And I can feel it moving between my hands, and she likewise can feel the space between my hands. I'm not doing anything complicated with this hand. I'm just got my hand on the back, and by moving it up and down, you can find different places there. So I call this the core breath exercise, or call it directed breath. The idea here is that you're simply using weight on the abdomen to direct the breath elsewhere. By the way, people are not supposed to breathe this way all the time. This is simply a way to expand the breath into new areas. Be careful that you haven't set somebody up to keep breathing in this way. So we used a restriction of the breath in front to expand the breathing into the nooks and crannies of the abdominal balloon, but we can work on the back of the abdominal balloon directly here. You have the erector spinae nearby, and outside, on the outside edge, you have the lateral raphe, which is a fancy name for a strong band of connective tissue that comes down from the erectors and the 12th rib to the hip here, kind of corresponding to the outside edge of the erectors and the quadratus lumborum, and where the abdominal fascia comes around and joins into that band of fascia. So I'm going to get right down on the hips, and I'm going to put my fingers into that fascia, and then I'm going to come up. And my advice to you, Sean, is to stay right on the bench. Don't let me move you off the bench as I use my fingertips to lift that rib up. And you saw that Sean took a deep breath in there, and that's a good idea for him to take a nice deep breath. But what I want is for him not to be moved up off the bench. Here's how I should not work. If I make this about my arms, like that. You feel how uncomfortable that is? Yeah? Okay. You don't want me to do that, right? No. This is more like a martial arts move. I come in under, and I use my hips to lift my hands. And I'm going right along the outside edge here, and when I get to the 12th rib, I can bring my elbows in and go above it, or I can just go under and have him use his breath to lift that 12th rib. Okay? This is a great move for opening up the back side of the abdominal balloon, especially if somebody's got a lordotic spine. Let's let Leah give this a try. All right, so we've got Sean sitting here nice and straight on his sits bones with the top of his head coming up towards the ceiling. So go ahead and find his iliac crest and back and get your fingers hooked into the tissue right over the edge. There, you've got it. Now, you'll want to come from under to lift your fingers up. Now, Sean, is that approximately what you were feeling with me?
Not quite.
Okay, I think you've got to get the tips of your fingers really in there first. So come from above to get in and get your fingers there. And now drop your elbows to lift your fingertips. And see if you can launch him off that table. Okay, is that more like it?
Yep, absolutely.
Okay, keep breathing, Sean. Good. All right, I want you to try this one more time, and don't lose your lower back. Keep your lower back, so don't go forward with your lower back. There you go. Go forward with your whole back, for sure, but don't arch your lower back. And come ahead and do that again. Come in, and up, and Sean, you just lift right out. There you go. Feel that? Feel what's happening to his ribs?
Mm-hmm.
Yeah, that's it. Get him to come right out. You can really take somebody who's got a short lower back or a lordotic lower back, and as long as you don't go lordotic yourself, you can get somebody to come up and out of there. So all of these techniques that we're doing here are concerned with the abdominal balloon, which maybe I didn't make clear. The diaphragm forms the top of the balloon, the pelvic floor forms the bottom of the balloon, The belly muscles form the front and the sides, and the lumbar spine and the psoas and other muscles around that form the back. So by putting my hand here, we were able to force the breath away from the soft belly wall into the other more obscure parts of the abdominal balloon in that technique. But now we're going to address ourselves to the belly itself, and particularly the umbilicus. The umbilicus is a funny place. It's one of the few places in the body where all the fascial layers from superficial to deep are tacked into one thing. It's like somebody came along with a heat seal and heat sealed them all together from the very back of the skin all the way down through the muscle layers to the peritoneum. So it's organic and muscular at the same time. Of course, it was our source of nutrition for the first 9 months, and it's right here in the very center of the soft underbelly. So it often has a lot of emotional content to it, and particularly for people of my generation who had the umbilical cord cut within 30 seconds of being born. Don't get me up on the soapbox, but there's leftover tension left in a lot of those folks. So how are we going to approach this? You could do work on the surface of the rectus abdominis to lift that up. We saw that in the superficial front line tape and somewhat in the spiral line tape. But now we're going for the deep front line, which means we need to go behind the umbilicus to get to that layer of the transversus and the deeper structures. So it would seem logical to come in like this with your hands, but if you do that, experience tells me you will leave fingernail marks on delicate abdominal skin. So if you come in this way with your fingernails up and your finger pads down, you'll do much better in terms of not marking up the skin. Secondly, you want to make sure you go behind the rectus abdominis muscle. So if you could lift up your head. Yeah. So I can clearly feel as soon as she lifts up her head where the edge of the rectus is, and I want to go behind that. So I'm lifting up that muscle between my fingers. So again, lift up your head, you see the muscle right there. Yep. Now, the technique is I drop my elbows to lift my fingertips. My fingertips are pressing into each other, behind the muscle, and kind of through the umbilicus, and I lift it towards the ceiling and towards her head. So there's two ups, up toward her head and up towards the ceiling. How are you doing?
Well,
A lot of sensation in this,
a lot
yes?
of sensation.
Yeah, so you have to gauge how much they can take with this. You can go a second time. I don't recommend working below the navel, but you can work above the navel. And lift your head. Yep, okay, we got it. And lifting up and lifting up. This can really help free the breathing in people for whom the belly is pulling down like this and restricting the breathing in front. So how's your breathing feel?
Much more expansive. Thank you.
You're welcome. All right. Potentially, you can really exert some force to lift this up. But you really have to go with what the client can take on this. It's once again, one of these really rewarding techniques, but has to be applied sensitively and within the bounds of what the client allows. So you just felt this, Leah, so you'll have the proper amount of empathy and compassion when you do it on Sean, who hasn't felt it yet. So go ahead and position yourself so that your hands are coming in like that on either side of the rectus. Now, if you want to check exactly where his rectus is, Sean, if you could lift your head up in the air and look at your own navel, then you'll be able to feel that really clearly, yes?
Yes.
And the object of the idea is to get behind it and to bring your fingertips together. Now, I know that's an upsetting thing. So you're not digging towards his back, right? It's a kind of scooping in to bring your fingertips
Can
together.
you just do that one more time, Sean? Okay.
And she should bring her fingertips together until you can feel it behind the navel, but it's not killer. Okay, now when you're there, drop your elbows to lift your fingertips towards the ceiling and also lift towards his head.
How's this for you, Sean?
That's good.
It should have, excuse me for the metaphor, but it should have a little bit of the feeling as if your belly button's being torn out by its roots.
So I am feeling that.
Yeah, okay. But within
Yes,
scope. Yep. Okay. So try that one more time a little closer to the head so you get the second one just a couple inches up, and running in, drop your elbows down so you can get behind the rectus and scoop it up.
And take another little nosedive towards your hose. Thank you.
Good, because you're really trying to get behind this and get the back lamina of the rectus abdominis and lift it up towards the ceiling and up towards his head. I'm just going to give him a little comparison here.
Okay.
So if I get a hold of that, something like this, something like that, and something like that. Yeah, is that where she was?
Mostly, yes.
Yeah. Okay. It's a novel feeling for many clients for you to do this, so go slowly. There's no harm in hanging out there for a little bit, as long as you're this side of them trying to squirm off the side of the table. So now moving up from the umbilicus to definitely the most important muscle of breathing, the diaphragm. It is an amazing, what would you call it, biological piston in the middle of the body going up and down, creating the breath, and all kinds of things flow out from this. Far more than we have time to talk about on this video. We're just going to be talking about the technique of getting here. Now, you saw in the superficial front line tape, we talked about freeing up the lower edge of the ribs here. And that will have an effect on breathing, but it's not touching the diaphragm directly. If you want to touch the diaphragm directly, you have to be at least an inch under the ribs. Now, there are places where you can and can't go an inch under the ribs. One place is right here. No fair going after the xiphoid process and trying to get in here. You can get the side of the ribs near the xiphoid. That's a nice little sore area, isn't it? But not pressing down onto the xiphoid. Also, it's more difficult where the rectus abdominis comes over the ribs because trying to get under here is trying to push that rectus out of the way. Actually, you're fairly soft and I could get under here pretty well. But for most folks, and you may not be able to, oh, somebody's got their belly like that, you're not going to be able to get down here at all. However, you can go right around the costal arch here, a little bit wide of the rectus abdominis, coming in and back up against the ribs. Do you see how my fingers are curling in? I'm not going down towards the spine. I'm coming up under the ribs and curling back towards the ribs. The second thing that's essential that I hope you can see here is that my hand is on top of the ribs. If I just do this without a supporting hand, kind of feels like I'm going to rip you apart, yeah? So if I put my hand here, this is a nice safety and security thing, so that then I can really go quite far under the ribs and you still feel what?
Well, I can feel where your hand is.
Yes, can you?
And it's good to have the top hand for support.
Now, the fact of the matter is you're not directly on the diaphragm until you're an inch under the ribs. That's where the diaphragm starts. It doesn't come right down to the end of the ribs. It's about an inch up from the ribs. So if I really want to affect the diaphragm directly, which is a good thing to do in cases of getting the breathing to be perfecto, then we'll really go in under here. Okay, now, take a breath. Okay, and then when she releases the breath, I go in a little farther. And then she breathes in, and I hold my fingers where they are. She breathes out, and if I can, I get in a little bit farther, but that's probably as much as you want me to come in, isn't it? Was that a yes?
Yes.
Okay, so
It's hard to breathe.
it's hard to breathe, so I'll go out a little farther now and take the same thing. Support with my hand, come in with my fingers, bring my fingers up against the posterior side of the ribs, about an inch in, and there's your attachments of your diaphragm. And she breathes. It's her breath that does the work. I'm not doing anything for work except maybe moving back and forth a little bit just to give her the awareness. And you can keep that going out till about where you are above the ASIS, north of the ASIS. Then you get into these floating ribs. You don't want to pull these floating ribs out too much. You can use some of the techniques that we saw on the lateral line for getting this, But this costal arch technique right in here is best right along that area. All right, Sean, let's give this same thing a try. What we're going to do is get in under to that diaphragmatic attachment. Nice and slow. You notice that he's outside the edge of the rectus abdominis and that he's put a hand. And how far can he go and still be your friend? Can you? Yep, just ease your fingers. You can. And again, it comes from your shoulder or even your body. It's just turning under her. That's it.
All right.
And so this is reassuring. So now take a nice deep breath and he'll feel your diaphragm coming down. You feel the diaphragm there? So each time she breathes out, you follow it up. Each time she breathes in, you hold it, and that's going to get a stretch and an opening at that attachment. Each time she breathes out, you follow it up. Each time she breathes in, you hold it and don't let her come down. Yep. So you maybe do that for 3 breaths worth in that spot, and then maybe go a little lateral to that. Come on out, and that's fine, the way you're doing it. Just move a little bit lateral, and get the next one. Good, and you can follow that out until you get to probably one more. When you get to the floating ribs, you have to stop. All right, have you gotten out as far as the floating ribs?
You're about there.
So, good. Let me show you another way to do that here. With your hands, kind of one hand at a time. I can use the heel of my hand to support her ribs, and my fingertips are going to go in under the ribs and capture the diaphragm attachment between the heel of my hand and the tips of my hand. So I take and curl right around the ribs, come up against the ribs there. You can feel that I'm at your diaphragm attachment if you take a nice deep breath. Yep. And so I follow you in on the out breath, and then open up this way. I know it looks like I'm really grabbing hold of her, but my fingertips are being opposed by the heel of my hand, so it just feels as if I've got you in a firm grip, doesn't it? Shouldn't be.
Very firm grip.
Oh, okay. Well, a very firm grip. But you can get in under here and really open up that diaphragmatic attachment to the rib cage. All right, let's go try something a little higher up. From the diaphragm, the deep front line passes up through the thoracic cavity. That would involve the anterior longitudinal ligament in the most posterior aspect, the tissues of the mediastinum, including the pericardium and the lung pleura in the middle, and the transversus thoracis and the endothoracic fascia in the front, all leading up through the throat, which we'll get to in a little bit. There are techniques for working this connective tissue, the heart and lung attachments, particularly that come from visceral manipulation. I think visceral manipulation is very concordant with what we're trying to do here. These techniques are too subtle and involve too much feeling to convey well on this video, but we do offer courses in this, and courses are offered in visceral manipulation in various places. Since we can't offer those kinds of techniques on a video, I would like to show you a fairly simple technique for using the breath that will help balance and extend the breath through these tissues. So if we were to look at the rib cage as kind of a box, and we were to say that we have the value of wanting to have the breathing expand in all dimensions, we've already talked about the diaphragm, how the breathing goes down with the diaphragm. We're about to talk about how it goes up with the scalenes. But of course there are 2 other dimensions, the side to side and the front to back. So the side to side idea, I can help that by working with the intercostals sometimes and with the abdominals, but just awareness is very helpful. If I take and put my hand on the client's ribs sideways and I say, now push my hands out with your breath. That's it. And again. And I can feel which ribs are moving and which ribs aren't moving. For instance, I've got my fingers, just put your arms to the side, Leah, on 6, 7, 8, and 9 right now. Yeah. And we already did a technique on the bench there for opening up the lower ribs to this, but it's not bad either to just put my hands on the floating ribs and say, can you push my hands back? Yeah, that's great. Okay, and we'll have another technique on the bench for getting up under here to get the upper ribs to breathe. But right now I'd like to focus on the front-back idea because definitely the motion between the front and the back of the body is the hardest to get in the breath. The up-down motion everybody has because everybody uses their diaphragm. The side-to-side motion most people have. But now this subtle and important front-back motion. So Leah's already doing this. She's breathing in such a way to try to push my hands apart. But that's what I would say to the client. I gently put the heel of my hand on the upper part of the sternum and the other heel of my hand back on the spinous processes of the thoracics, and I say, breathe my hands apart. You'll be amazed at how few people have any dimension of breath this way, and if they do, sometimes they rob Peter to pay Paul. I'm going to move you now. They push the back forward to push the front forward, or they push the front back to push the back forward. That's not expanding through here. What you really want is that your two hands move apart from each other. That's number one. And the ideal would be that the front hand moves away from the midline and the back hand moves away from the midline. It's very few breathers that have that kind of dimension to their breathing. But all you have to do is put your hands here and encourage people to breathe, and all of a sudden they'll find unknown dimensions of their breath by trying to get that action to move. I do ask people to really exaggerate their breath at the beginning, because then they can feel that motion, and then try to get that same motion into a normal breath. So we can extend this idea of breathing out to the sides up to the upper part of the rib cage that lies under the arm. Rib cage gets smaller as you go up here, but it's very important that these ribs breathe too. So Leah, if I can get you to raise your arm, I'm going to put my hand right in the armpit so that my fingers are right in the softest apex of the armpit. I'm not doing anything except placing my hand there, and you drop your shoulder down over my hand. So here's my hand up into the armpit, and I'm going to go up along those ribs as far as I can. I might even lift the shoulder a little bit, but it shouldn't hurt. Yeah?
No, it doesn't hurt.
And I'm just got my hand on her other shoulder so I don't push her over this way. Now I'm just going to crook my fingers a little bit into the ribs and have her breathe. Can you feel that rib?
Yes.
Yeah. So there's the fourth rib below it. Yep.
Yep.
I can go up to the third rib. Yep, she's moving that one. And I can go up to the second rib. And if she allows me, I could even go up almost to the first rib, between the second and first rib. And Leah's got a lot of good breath moving up in there, but a lot of people won't, and you'll be able to increase that breath out to the side by doing this on either side. Just want to emphasize, this is not a doing move. I'm not trying to scrape fascia, open things. I'm just using my awareness up the various ribs to get her to breathe out and up with those upper ribs. Now, the pectoralis minor and its associated fascia technically belongs to the deep front arm line. But the deep front arm line is really the extension of the deep front line out into the arm. The connections with the on from the pectoralis minor are into the superficial front line. However, functionally and viscerally, it connects out through the thoracic inlet into the arm. So we're going to put a little reprise of the pectoralis minor technique in here. However, if you want to get more detail on this, check into the arm lines programs. Okay, you can see that my fingers are coming in just underneath the pectoralis major here, and I'm going up under Leah's armpit while she watches me watchfully. And then I'm going to bring her arm down over my hand. Anywhere you can rest it there is fine. And just taking hold of her collarbone so that she doesn't feel as if I'm trying to drive her off the other side of the table. I don't go into the ribs, I go up along the ribs. And there is the pectoralis minor and the costocoracoid fascia that I can find in along here. And we're just going to ease that up toward the tip of her shoulder, opening up the deep front of the armpit and allowing her to drop the shoulder back on her body. So you can bring your shoulders down and together in the back. Yeah? Now, you'll notice that I'm staying in contact with her eyes. I'm very interested here in not going so deep and so hard that I have her trying to get away.
I
And this-
appreciate that.
Okay, good. And it's a very difficult place to reach. You can do it with the arm up here. Obviously, it would be easier to see, but it's a little more difficult for the client because the muscle's stretched out. So I prefer bringing the arm down just to soften the tissue. Makes it easier to open. From the inner surfaces of the ribs and all these visceral connective tissues, the deep front line passes up into the neck. The principal muscles that we're going to work with here are the scalenes and the longest muscles on the front of the neck. Let's start with the middle and posterior scalenes, which act as the quadratus lumborum of the neck. We're not doing a lot of assessment on these programs. You can refer to our specific programs on assessment. But this technique with the middle and posterior scalene is such a no-brainer. I just wanted to get this in here. If you look and you see the distance between the ear and the shoulder on one side is significantly different from that distance on the other side, you can be pretty sure that this is the side that you want to do this pin and stretch technique that we're about to show. You'll really see a change in the shoulder level and on the centrality of the neck if that is a problem. So let's go on to the technique. So if you remember, Leah had a shortness on the left side of her neck, so we're going to work in here. Now, finding these middle scalenes, if you strum your fingers along the side of the neck, just behind the sternocleidomastoid. Obviously, the muscle that's most on the side of the neck is the SCM. But underneath that, more like a cable than a muscle, is the middle scalene. The middle scalene is almost always the most lateral. So if you strum across the neck, that's the one you're going to find. If you put your middle finger on that and then your ring finger on the one behind it, just bring it in around behind, you have the middle scalene and the posterior scalene, which, as we said, was the quadratus lumborum of the neck, in your grubby little mitts. So I'm going to take that and pin it down against her ribs and then invite Leah to take her right ear to her right shoulder. Now, we want lateral flexion here, not any rotation. A lot of clients, when you say, now take your ear to your shoulder, they'll do this. That's not what you want, a rotation. What you want instead is a lateral flexion like this. And if you do that, it'll really come down and really open up the top of the breathing and the upper ribs. Once again, as I said before, if you're getting tingling down the arm, you need to move back a little bit because the brachial plexus is right in front of the work you're supposed to be doing. If you're getting tingling, you're just a little bit too far ahead. All right, let's let Sean try this. So, Sean, what I'd like you to do first is to make sure that you can find her lateral scalene, the middle scalene, which is the most lateral one. You feel that cord?
Yep.
Okay, so you want your middle finger on that cord or your index finger on that cord and the next finger just behind and inside of it. You'll feel a little pocket that it fits into, just behind it. Mm-hmm. Yep. So you're going to pin both of those, the cord and the thing just behind it. What you don't want to do is to get just in front of it because that's where the brachial plexus is. If you want to see her jump off the table, you can go a little bit forward of where you are. No. Now, the idea is to pin those two muscles down against the upper ribs. Wait, don't move yet. Let him get pinned. Okay. Yep. All right, and now you can use your hand to guide her head over to the side, a lateral flexion away from you. So she's doing the stretch. Now she can either do that movement voluntarily herself, or as with Sean here, she's doing it passively. Try taking your hand off and see if she can. No, I'm sorry, not that hand. Keep this head pinned down, and you go ahead and move your head away from him. So we'll just do it with a little bit of hair pulling here. Yeah, that's it. Okay. When you're at the end, you're at the end. Then you let go when she comes back. Yep. Okay. Does that feel the same? About the same?
And now I feel I'm about this long.
Yes, and now you feel you're about that long. I guess we better do the other side, huh? Okay. Now, the anterior scalene is a little different from the other two. It goes down and forward, kind of like the psoas of the neck, down and forward from the transverse processes of the cervicals to the first rib. In that way, it can, as it tightens, restrict breathing, but also pull the neck down and forward towards the rib cage, or indeed, it can end up pulling the rib cage up and towards the neck. So when you see these patterns with the lower ribs sticking way forward, one of the things you need to release is the anterior scalene. Now, these are complex muscles, and a lot of things would apply to different patterns, so we'll be showing you a couple of general techniques for releasing this. One caveat applies, though. We need to avoid that brachial plexus. Cease and desist if your work is creating tingling down the client's arm. Now, I'm putting this technique on video with a little bit of trepidation, so please listen up and please do it carefully, slowly, gently, and as I'm telling you, because the carotid artery is not far away from here. So, if you want to get to the anterior scalene, you need to go under the sternocleidomastoid. So if you put your fingers on the side of the neck, just lift your head up to the ceiling, you can see that sternocleidomastoid very clearly right there. I'm going to put my fingers behind it, and I'm going to slip under the part of that muscle that goes to the collarbone. If I'm on top of it, I'm working on that, not on the anterior scalene. The anterior scalene is about a half-inch band, very sturdy, very strong, right underneath it. Now, if I put my fingers here and you take a deep in-breath, you will feel the anterior scalene working on the in-breath. For some people, it starts at the beginning of the breath. For some people, it only engages at the end of the breath. For some people, it works all the way through the breath. But sometime during the breath, you'll feel it contract, although it doesn't really contract as much as it just gets hard in its contraction. It keeps the upper rib from going down. So, if the head is pulled forward or the lower ribs are pulled forward and I need to open up this anterior scalene, which is very common, then there are two ways of working. I can pin it and have her work against it, the same way we did with the lateral scalenes, or I can work with it. So first, here's the first technique, which is working against it. I'm going to go down on that anterior scalene and pin it underneath the collarbone to the first rib. You okay?
Mm-hmm.
Yeah.
I'm all right.
You're all right, and you're not
I'm not getting any tingles.
and you're not tingling down your arms because the anterior scalene is just in front of the brachial plexus. Okay. So now, bring your chin in and slide the back of your head up towards me. So she's lengthening the back of her neck, and she's plastering the back of her neck to the table. And I'm keeping this pinned down to the first rib. It's really simple. I'm not doing much. And she's doing most of the work by, try stepping on your feet. You can even make it more happen. She is bringing those lower neck vertebrae back by sliding her head up the table to me. Okay? So method number one is a kind of pin and stretch, but instead of going from side to side, she is going front to back by extending the back of her head towards me. If the client lifts their head up off the table, go ahead and lift your head up off the table, everything's going to contract and you're not going to get anything done here. So the idea, and it doesn't feel very good either, right?
No.
So the idea is to slide the head up the table. Now the other way you can do is an active release technique to get the muscle to come with you. I'm going to go ahead down to the attachment here, but this time when she does the same motion, bring your chin in and slide your neck, I'm going to come up the muscle with her from the insertion towards the origin or the lower inferior attachment to the superior attachment on the anterior tubercles of the 3rd, 4th, 5th, and 6th cervical vertebra. Just find that little half-inch band and see if you can help stretch it out. Okay, so now take a breath and tell me what it feels like. Does it feel any different?
It's going way up.
It's going way up. That's right, because this helps the motion of the breath go into the upper ribs. For some people, that's what they'll feel. For other people, they'll feel as if there's more space under their neck and, I'm sorry, not more space, less space under their neck where the neck has come down against the table. Okay, let's see if we can learn anything more by having Sean do this with Leah. Just follow the red marks. I think you'll be all right. So you found that lateral one on the side. Now you're going to turn your fingers that way, and you're going to lift the sternocleidomastoid out of the way. Just soften your hands a little bit. Okay. So lift the sternocleidomastoid out of the way and slide in medially underneath it. And you should feel a half-inch band underneath there. That's pretty strong, pretty hard. About a half an inch wide. Yeah? Have you got it? Has he got it?
I believe so, Tom.
Okay. Well, take a deep breath, and that'll help him find it. I think you got it. All right. So, but I'm going to ask you to come even more medial. Take a deep breath and you take a deep breath, yeah. So, and come more medial on that so your fingertips are closer to each other. Yeah? Is that still all right?
Yes.
As long as it's not choking off your breath or sending tingles down your arm, you'll be all right. And you watch what color. If she changes to beet red, then you don't want to do anymore, but I think you're in good shape. Okay, so now pin that down against the ribs, and we're going to invite Leah. Bring your chin in and slide your head up. You feel that stretching underneath your fingers? Okay. And you can even augment that, Leah, a little bit with pushing on your feet.
I'm doing that.
Yeah, you're doing that. Okay, great. All right. And the other way to do this, sometimes either way they're effective. You start where you finished here, which is down in there. Do you need a break or are you all right?
No, I'm all right.
Okay. So come in on top of that anterior scalene. And now as she breathes in and as she pushes and as she elongates, you're going to come up that muscle toward the top, which means it's going to get narrower and towards the midline. As you come up the muscle, you're going to be coming up towards those TPs on the cervicals. Is he doing it right?
I think he's just missing that bringing it up part.
Okay. Let's guide his hands in here. Okay. That's it right there. Yeah. And now take a breath, and as you exhale, push that down. That's it. We're going to follow that right up the neck that way.
That's better.
That's better?
Yep.
Yep. And you see she is beginning to change colors a little bit. So you want to do this with dispatch and
sensitivity,
but you don't want to hang out there too long if they're starting to change color. Okay, you all right?
Yes.
Yeah.
Very all right.
Is that about enough of
That's
that?
about enough of that.
Okay, good. Let's try something else. So there's one more technique here at the top of the deep front line that I really want to get to because the muscles and fascia involved are so important, the front of the neck. But it's also a place that's difficult to get to, so you should tackle it if you feel competent to. The same thing applies. Lift the sternocleidomastoid with the fingernail sides of your fingers, and you'll feel a hard bit, which is the scalenes that we've been working with. And we're going to slide in right in front of those scalenes. Right in front of that, but behind all the stuff of the throat. The idea of reaching these muscles from the front, coming in through the front like that, is in my opinion, not a great idea because of the possibility of getting the carotid artery or the vagus nerve between you and the front of the neck vertebrae, which is where we want to be. The longus colli and longus capitis are muscles in there, and what we want to do is contact them. Now, there are two situations here. One is the situation of a military neck, which usually comes from somebody who's had several whiplashes or something like that, where the neck is too straight. The far more common condition is the opposite one, where the neck is hyperextended and there's a big space behind the neck, and I doubt the chin would be that far up, but anyway, the neck is like that. So we're going to do two different techniques. The first one is for if the neck is hyperextended like this. If you're seeing a pattern like this with the head forward and the neck retracted, then these muscles don't need to be worked in the sense of made longer. They need to be strengthened. So longus colli and longus capitis are kind of like another part of the psoas of the neck in that they're going to help hold the cervicals back. So my intention in getting on the front here is not to smush on tissue, not to lengthen muscles, just to give Leah an awareness, just to give the client an awareness of where this is. So now, once again, Leah, slide the back of your head towards me. Try to plaster the back of your neck down on the table without lifting your head off. In doing that, she has to exercise these muscles. It's the only ones that can flex the neck without lifting the head off the table. And so every time she does this, she strengthens it. And I can help her do that by bringing awareness to the front of the neck. You'd be amazed how far the fingers can go under here without causing injury if you stay right in the division between the hard bit, which is the motor cylinder that goes around the back of the neck, and the softer visceral cylinder. Don't go through the visceral cylinder, don't go into the motor cylinder, just come right behind the sternocleidomastoid and go between. And now if the neck is hyperextended, as mine is right now, then bring your chin in and slide your head up towards me. Great. Okay, but what about if it's the opposite? What about if the neck is already too straight? A military neck or a reduced or reverse curvature in the neck. In that case, you do want, these muscles are too tight or fascially too tight or muscularly too tight, and you do want to loosen them up. So in this case, same thing. I would come in under the sternocleidomastoid, come over to here, and now I would invite Leah to do exactly the opposite. Take your chin up, and in this case, I go along the front of the vertebrae, opening them up. I think you can see on the video that Leah is getting a nice, healthy pink color, but she is not turning as red as a watermelon or as red as a beetroot. You don't want somebody, if somebody's turning all colors of red in this, or worse than that, blue, stop. But how else can you reach in and get a hold of these muscles right on the front of the neck? Remember, if it's a military neck, you want to work the muscles. If it's a hyperextended neck, they want to work the muscles by bringing the chin in like that. Great. Okay, we're going to leave this one as a demonstration. You've seen a lot of techniques here for the deep front line. There are many other structures and techniques here for the hyoid muscles and the muscles below the tongue, and even the intraoral work. And that work is too variable and is just not suitable to be taught on video. So if you want to learn those techniques, we hope to see you at a Kinesis professional training class. We hope you've enjoyed the techniques that we've got on the video, and let's wrap it up. Well, that about brings us full circle on our journey through the techniques based on the Anatomy Trains myofascial meridians. We found techniques for the front line, and the back line, and the lateral line that run straight up our body, the spiral and functional lines that run circles around us in rotations, and our arm lines that connect our trunk with our doing, and the deep front line that runs right up the core of our being. We hope you enjoyed these programs and found something useful in them to use in your practice. And since we're always developing this idea, we hope you'll stay in touch with the office and the website to see what we're cooking up next. There might even be some extras on this DVD. Anyway, we wish you good luck and good skill in your work. body and spiritual development, and about 30 years a Rolfer, and 20 years maybe a teacher, and director of a school now for the last 6 or 7. It's been a progression, and boy, has this profession changed over the time that I've been doing this. When I first started in on doing massage, it was really seen. When I started in on doing massage, it still had associations with adult entertainment, sexual favors, and that was something we had to get over at the beginning. But anyway, even therapeutic massage was seen as a break from the stress of daily life. You came in, you lay on the table, you drooled, you went away to the pink beach, somebody took care of your body for an hour or so, and you came back and you were in better shape to go back to the fray. And God knows that's still a valuable profession as a whole changed over that time from the if you'll forgive the thing, I mean it in the old biblical sense. I don't mean a bad word, a bad sense of the word servant. You were providing a service for your clients. And then, really because the medical system had absconded from the subclinical, not acute, musculoskeletal things, massage therapy moved into that domain and really took over. Has done very well at that, and these are the things like myofascial release and trigger point work and other forms of what's now called orthopedic or medical massage. And as the name implies, this is more like being a doctor or a professional to your clients. You have a particular expertise. Somebody comes in, they have a problem, they want you to use your expertise to fix it. And although we're careful not to use words like diagnosis, we do end up with third-party payment for these kinds of work. And this, rather than the practitioner being the servant of the client, this reverses the roles. The practitioner is the professional, the doctor, the expert, and the client comes in and pays for the expertise. I was fortunate, I think, to come into this work on neither of those levels. Through meeting Ida Rolf and by doing her work, what's really being looked at here is the integrative level. Now, when you come into an integrative therapist, if somebody, God knows we all practice these different levels at different times, but the general attitude with which I try to work, and I'm kind of recommending that you work by doing this little snippet here, is a co-equal relationship. I'm a human being with my expertise and my faults and my problems, and you're a human being with your expertise and your experience and your problems and limitations, and you come in and we just set up a team. What can we do to make your body, I was about to say, work better? But the slogan of my school is change your body about your mind. The thing that is so much ignored and not taken care of in this day and age is the idea that the body and the mind are one. So that, well, you go to a massage therapist for your body and you go to a psychotherapist for your mind, and some drugs affect your body and some drugs affect your mind. All drugs affect your body. All treatments affect your body, and your mind is not a thing. Minding is something that bodies do. So with this idea, the whole kinesthetic body, the whole sense of the body in space, is part of our consciousness, and part of our consciousness that is not really tackled. Not in giving parental skills. It's barely tackled in school. Yeah, okay, you have PE, physical education. And I hope it's better now, but in my day, it was a lot of preparation for industrial work. It was a lot of repetition and a lot of competition. And it did not really prepare a body for living in this life. Prepare a body for emotional shocks. Prepare a body for physical shocks. Prepare a body to use itself properly, no matter what the exercise is. I joke with my students that whenever I get the urge to exercise, I just lie down until it goes away. I think that's a Woody Allen line, but I love it. And as I've gotten later in life, I've taken up exercise, and during my life I've tried different things, but I don't think I'm less in my body because I'm not exercising daily or out there trying to do rock climbing or any of the things that I did try to do when I was younger. Your kinesthetic sense is part of your consciousness. We're really hip to our mental clarity and what our mental processes are doing, and we're getting more hip as a society to what our emotional processes are doing. So let's put it this way. There's IQ. There's your intelligence quotient, which measures the intelligence of your brain, which is a useful thing to do. And we've had several books, and people are getting more conversant with the idea of emotional intelligence, that there's an intelligence within the emotional system. And I'm here to promote KQ, that there's a kinesthetic intelligence. We have no idea how to measure it. I think a great deal of kinesthetic intelligence is on display in Vest Pocket Parks in New York, where kids are doing layups with beautiful precision and poise and body control. And I myself, being a white boy, was and have been very awkward. You still don't want to get me out on the dance floor. That said, I still have kinesthetic intelligence, which, having gotten into my body through these methods of Ida Rolf and many, many other people, Emily Conrad and Judith Aston, and the whole somatics idea, all the explorations that I've done over many methods over many years, they've all been useful, and they've all brought me into a sense of my body, which I now use intuitionally and in my daily movement to keep me healthy. Now, I think there's a lot of people for whom that simply is not a resource. And bodywork is one way to make that a resource. Better education in schools would be another way. Instead of training people for the 20th century, which was training people for industrial work. Now, what is industrial work? You do repetitive motions again and again and again on the line, and you do it competitively. You do it as fast as you can so that you can get as much out. Now, a lot of social analysts have shown us that the industrial era, even though we will continue to produce things, is over, just as the farming era, the agricultural era, is over, even though we continue to grow things and eat. It's not the whole basis of society. We're moving from the industrial era into something else. People have called it the information age or the service age. It's not really for us to name it, because the people who come after us will name it. And in this age, anyway, anything that can be done repetitively is done better by machines. Cars are built better by machines. Airplanes are flown better by machines. I'm glad there's a guy up front, but if they're coming in the fog, I want to know that it's resting on a machine. Those things are happening really easily. Anything that's repetitive, including writing a romance novel, can now be done by a machine. They've got computers writing romance novels. So what we want to train our kids to do are not the repetitive things, but the unique things, the individual things. Can we find ways of teaching children how to find their own individual kinesthetic intelligence? Where is their body intelligence? Right now, it's not being used at all. Hardly. There are, of course, dance programs. There are, of course, athletic programs, and those are all great. Those are two forms of expressive endeavor that are great. But not everybody's going to be an athlete, not everybody's going to be a dancer, but they still have worthwhile stuff to get out of exploring their kinesthetic intelligence. So the various things that I've done in doing therapy and these video programs that we've put out are all in the service of this idea. How are we going to educate the next generation to use their body? I can expand this out a little wider, which is to say that the challenge of the 21st century, one of the biggest challenges, it seems to me, is that we are moving ever farther away from a natural world. Of course the world is natural, and of course human activity in it is natural. I'm not trying to get us back to the 18th century. Or, not that the 18th century was that in touch with the natural world. But if you can go back to whenever you think everything was pristine and wonderful. I don't care when it is. You're not going to get back there anyway. We have a nervous system and a body that was developed for conditions 70 or 80,000 years ago. Our body has hardly changed in terms of its physiology since then, maybe a bit. Certainly the startle response, grasping fingers, there's all kinds of reflexes that we see that are left over from millions of years ago. And more and more we live in a world that is divorced from that natural world. My daughter thinks that chicken is something that arrives on a tray. She has no, in one of those plastic trays with film over it, she has no connection to the bird, certainly not to killing the bird, plucking the bird, skinning it, cooking it, well, cooking it maybe. But there's so much that is divorced from the direct experience. Now, how kids are going to live in that world. We're not going to take the video games back. We're not going to take the computers back. It's an exciting new world that they're exploring, but they are still embodied. And you don't have to look very far in the youth to see that their use of that body is less than sterling. And the more that they get into this artificial world, the less the use of that body comes. Now, part of the answers to this are traditional, going out to summer camp, get out and do some exercise, change the programs in the school. But part of it is a real change in attitude towards what constitutes that body intelligence, and how can we bring that body intelligence forward in the next generation. Because no matter what they're doing, computer jockeying, plane jockeying, riding around in a car, you can still do that intelligently with your body or not. Of course, I think it's much more important than just riding around in the car. I think the emotional responses and emotional maturity and the ability to receive, digest, and then have an appropriate response to things, I have to say that in my own case, it really rests on developing my own kinesthetic intelligence. This is why I have come to work with massage therapists, is that they have a sense of this wholeness, have a sense of this need, without being too linear in their thinking. If I'm frank with you, I think the education in massage therapy is pretty rudimentary compared to osteopathy, chiropractic, or some of these other things. And the same goes for yoga. Wonderful science, a very interesting experiment in exactly what I'm talking about. Yoga is a form of physical education with a lot of depth to it, but it was formulated for another society in another century. Here we are bringing it over to the West. Pilates, even a couple of generations ago, developed for a different time, a different zeitgeist, a different set of people, really. So how do we develop it for this time? How do we get this to shift? I do think the schools, obviously therapy is one of those things, but doing therapy one person at a time, that's a very slow way to change the world. Getting into schools would definitely be valuable, and getting to parents, getting to the parental skills so that children are handled in a way that they value themselves and their body movement. Parents want to do right by their children, and this is really an opportunity for us to make a change. Even though you might have watched these videos in a mere 10 hours, it was 7 years ago that we started the videos using a boat to demonstrate the idea of fascial tensegrity, and now we've completed the journey around the anatomy trains. The anatomy trains has a wider significance than just another way of looking at the myofascial system. The fact of the matter is that our way of looking at the myofascial system has been, because we started out with two things. One is that the Renaissance anatomists, like Vesalius, one of my heroes, and Albinus and Leonardo da Vinci, when they started out to examine a body, they did it with a knife. They did it with the same tools that hunters and butchers use to cut up meat. And when you go into the body, the skin comes off of the rest of the body, add a layer of connective tissue. The muscles are separated from each other by layers of connective tissue. The organs are separated from each other by layers of connective tissue. They're hung on to the spine with strings of connective tissue. So these were natural places to cut. The connective tissue system was never really examined as a whole. I sometimes joke that if I had a time machine, I would go back to Bologna or wherever it was that Vesalius was working, and I would take away all his knives and put a big vat of furniture stripper there. And so then he would come in and take this body and stick it in the vat of furniture stripper and strip away everything that was cellular and leave this extracellular matrix, this fascial net that would be one net from head to toe, that would go from the scalp to the bottom of your feet. It would include the net within the bones. The bones would be about like leather, the cartilage like slightly more supple leather. If you took all the stuff away except this fibrous net. There's two reasons for this. One is that it keeps getting cut up with knives, and two, it's considered to be the dead material in between. I'm going to take issue with that. I'd argue with that idea that the connective tissue matrix is dead. It's just been the stuff that's been stripped out of the way to get at the other living, interesting stuff. So nobody's really considered it as a system. That goes for all the branches of medicine, but let's cut this down to the myofascial idea, massage and manipulation. We have defined the action of a muscle as what that muscle would do if you stripped every other muscle off the skeleton, left that one muscle in place, and approximated the two ends of the muscle along the direction of the fibers. That's how we say what a muscle does when it says action in a book, in book after book after book after book. The action of the muscle, the biceps, is defined as going from the radial tuberosity up to, say, the coracoid process. So therefore it is a supinator of the forearm, a flexor of the elbow, and a diagonal flexor of the shoulder. And that's how we have defined it. And opening this up to a more systems point of view is a very important thing for changing how we think about these things. If we say the biceps is something that goes from the side of the thumb all the way up the arm to the shoulder, down to the third and fourth rib and beyond, that says something else. It puts the biceps in context. It's actually true. It actually is connected. The thing that disconnects it is taking a knife and mentally stripping it away from the brachialis, from the radius, from everything else, and just seeing it as an object, as if we were a car and we were made up of parts. But we're not a car and we're not made up of parts. You know, if you think of a tree, you think of the roots and the trunk and the branches and the leaves. And if you look at the leaves, you'll see they have a cuticle and then stomata and then veins and something ophils, and then you look at the veins, and they have outer and inner, xylem and phloem, whatever it is. I'm not a botanist. I'm not going to be able to take this very far. But we just break everything down into analysis by breaking down into smaller and smaller parts, and look what is the contribution of the part to the whole. But we're not really looking at, well, what happens when you put the wholes back together? If you think of the biceps as part of this structure that goes all the way down from the thumb to the ribs, then you can see that the biceps, the tonus of the biceps, the recruiting of the biceps, the engagement of the biceps in movement has to do with the stability of the thumb for people who are doing any kind of thumb work like trigger point work or shiatsu work. It has to do with keeping the chest open and breathing. You can open the breathing by working on the biceps in certain people where that's the restriction. And if you just think of the biceps as a part, like a spark plug or a carburetor, you don't get that sense of its connection to the whole. It can't be taken out and replaced. I know, we take things out and replace them these days surgically, but it's not, we don't grow that way. And we're not able to grow things that way. And if we don't widen out our perspective and start to think that way, we are not respecting the legacy of Einstein, the legacy of Jung, the legacy of Heisenberg, the legacy of folks who showed us that it's a relational world. All this analysis of the muscles is based on a cause-effect world, and we're looking at a relational world where things are interrelated in systems kinds of ways. So the anatomy trains, not to be too grandiose about it, the anatomy trains is a systems method of looking at the musculoskeletal system. It sees not 600 muscles, it sees one muscle. there's one mind, there's one muscle. It just hangs out in 600 fascial pockets, but those 600 fascial pockets are not separate. They're 600 fascial pockets in one big fascial suit. And if you understand that one big fascial suit and the interactions of the muscles within them, muscles can have actions farther along than their attachments at one end or the other, or actually broadly, which the anatomy trains doesn't even address. The muscle can act on muscles next to it in its region. And we haven't even begun to explore that idea yet. Okay, we're going to leave this one as a demonstration. You've seen a lot of techniques here for the deep front line. There are many other structures and techniques here for the hyoid muscles and the muscles below the tongue, and even the intraoral work. And that work is too variable and is just not suitable to be taught on video. So if you want to learn those techniques, we hope to see you at a Kinesis professional training class. We hope you've enjoyed the techniques that we've got on the video, and let's wrap it up. Well, that about brings us full circle on our journey through the techniques based on the Anatomy Trains myofascial meridians. We found techniques for the front line, and the back line, and the lateral line that run straight up our body, the spiral and functional lines that run circles around us in rotations, and our arm lines that connect our trunk with our doing, and the deep front line that runs right up the core of our being. We hope you enjoyed these programs and found something useful in them to use in your practice. And since we're always developing this idea, we hope you'll stay in touch with the office and the website to see what we're cooking up next. There might even be some extras on this DVD. Anyway, we wish you good luck and good skill in your work.